Yeah. All right. I think we'll get started here. Welcome everyone to the South Big Data Hub's Data Science Roundtable, which we will be doing monthly. However, while we're doing it at the Renaissance Computing Institute at UNC Chapel Hill, the first one and this one, we do hope that folks on the phone, if you would like to participate and host a roundtable at your institution, we would love to be able to rotate this around the entire hub. So I'm very delighted today to have two phenomenal researchers, phenomenal speakers, and people who have done great things within the hub, particularly in health informatics and mobile health. So by harnessing the power of individuals and engaging them in monitoring and managing their own health care, and by generating health monitoring data from large populations, we hope to use new wireless and connected technologies, mobile health technologies, to improve healthcare and lower costs. Yet we have several challenges, including how reliable is the data from wearable devices, how can that data from sources like cell phones, social media sites, EPA monitoring, EMS, crime reporting, etc., lead to a fuller picture of patients' environment and behavior and their care, who owns the patient-specific data, what are the policy implications, and so forth. So first I'm going to introduce Dr. Gari Clifford, and then after he gives his presentation, we'll have a follow-up presentation from Dr. Santos Kumar, and then we will open it up for roundtable discussion. For those who are on WebEx, we've been using the chat mode to write your question, and then we will ask and relay. But if everybody put their mic on, maybe we could have more, since it's a smaller group today, have a fuller conversation. We can try that, right? So Gari Clifford is the interim chair of Emory's Department of Biomedical Informatics and associate professor of biomedical informatics and biomedical engineering at Emory and Georgia Tech. He trained as a PhD in neural networks and biomedical engineering at University of Oxford and is a postdoc research fellow at MIT. His research focuses on mobile health informatics, critical care data, analysis, and applications of signal processing and machine learning to medicine. Specifically, he focuses on scalable and affordable healthcare, finding ways to use state-of-the-art signal processing, machine learning, and physiological modeling to reduce costs, increase accuracy, and improve access in healthcare using enormous data streams through data fusion, prediction, and developing confidence intervals and trust metrics. And Gari was just awarded one of the Hub Spoke Awards. So we're very, very excited bringing together many partners to do some great things. So with that, I'll hand it over to Gari.
Thanks very much. All right. So I'm delighted to talk to you today. This is a joint talk actually between myself and Dr. Herman Taylor, who I stole half of these slides off because this is truly a joint effort. I'm going to talk to you about something we've been hatching for probably about 18 months now, and I've also been getting off the ground at the same time. So this originally is focused around cardiovascular disease, and as you can see, this has been climbing steadily over the last century, at least until about 1960, and it became a significant public health problem, or noticed to be a significant public health problem in the 50s and 60s. In response to that, there was something that most people in the cardiovascular disease world know about called the Framingham Heart Study, which is an enormous study following 3 generations of patients and volunteers, tracking their cardiovascular parameters from year to year and building the quintessential cardiovascular disease risk prediction models. And then what we saw as a result of this kind of study and the technology and interventions that occurred from this is a drop-off in the rate of mortality from cardiovascular disease year on year. However, there are some subtleties to this. Even though globally, or rather nationally, and in developed countries, we've seen this decline in cardiovascular disease rate, there are geographic disparities, and you can see here, the redder the location, then the higher the average annual mortality rate per 100,000 people. And you can see that there's a very strong band that runs through the southeast, and that's particularly pertinent to us in the South Big Data Hub. Not just that, but there's a disparity within the populations that actually live in those locations as well, and the minority populations have been significantly affected by this more than the non-minority populations. In response to this, the Jackson Hart study was a study similar to, in many ways, to the Framingham study, but focused on an African-American cohort. Over 5,000 men and women aged 21 years and older were followed over a period of several years, and they had a reasonably impressive return final visit rate of about 80%. And they developed new models from this to create minority population-specific CVD risk prediction metrics. And this is, again, most of these on the early slides are Dr. Herman Taylor's slides from the Morehouse School of Medicine. And he's quite modestly put incrementally predictive here. And even though this is a seminal study in the African-American population, he's right in that there's only so far that we can go with these types of yearly visits or biannual visits for patients coming in and doing blood tests and reporting on risk factors. So there's a large heterogeneity in the population. There's rare sampling. It's very expensive. It's very labor intensive. It's basically only observational, and the engagement's quite difficult. And I'll get back to this again later on, but you can see on the right-hand side here it says reasons for non-adherence in the Jackson Hart study, and the number one reason that over 50% of the population gave is they were in a hurry, too busy, or they forgot. The second most frequent reason for non-compliance was it's inconvenient. So there's a large attrition in these kind of populations, just because it's annoying to be a participant in it. So one of the questions is, how do you retain people in these studies as well as get higher resolution data on them continuously? And of course, we're talking about this because we know that there's this enormous explosion of the Internet of Things and mobile health devices where we can facilitate precise and big data, data gathering, implementation and planning projects with this enormous volume of data coming in. The Jackson Hart study took 3.5 years, 11 full-time recruiters to get 5,300, which is an exceptional result. But if you look at something like Healthy Heart, they enrolled 1,000 people in the first 5 days. Now, Healthy Heart is not a high-density data collection system, but it's still extremely impressive how quickly you can recruit people into an mHealth cohort like that. So there are massive-scale mHealth clinical trials underway now, and this allows real-time assessments and interventions that can be launched at scale via the user's own mobile phone. What's particularly exciting for me is a researcher who does signal processing machine learning and likes to get somewhere near the Nyquist limit for sampling, is the high resolution of data that's possible through mobile phones. If you look at on the top right there, that's a screenshot of Google Fit, where they're phenotyping your activity in terms of cycling, walking, running, telling you approximately how many calories you've burned, and tracking where you're doing this as well. And this is just an app that Google released through their own operating system, and also have an API for you to hook into. So you have this opportunity to collect fairly high-resolution data on a daily basis. You need no compliance for this except installing the app. It runs in the background. It's convenient to use. It's continuous. It's highly multimodal, and as I'll describe in a minute, and it links to wearables very smoothly. So we're becoming more and more familiar with these type of wearables. This is the Samsung Sinband platform, and we're able to capture fairly high-resolution data off these devices. One of the issues with capturing this information, of course, is how noisy is it and what do you do with it? And that's one of the aims in our NSF grant, is to leverage the experience we have in dealing with these noisy data streams in order to create trust metrics. Many of you probably noticed that Fitbit recently had a class action suit against them because they made a claim that they were not going to miss a single heartbeat. Well, if you have a wearable device on your arm, you're probably going to miss 60 to 80% of the heartbeats if you're very active. And the problem is wearing a wearable on your arm is a bad place to be recording your physiology. So there's a trade-off between convenience, compliance, and the quality of the data. And that's exactly what we're addressing in one of the arms of their grant. So I said it's multimodal. So there's a whole bunch of things that you can record from your mobile phone and connected devices. This is just an activity from a wearable in a schizophrenic population, in a borderline personality disorder population. On the left-hand side, this is a 24-hour activity over several months of a control patient, and on the right-hand side, you see the activity of a borderline personality disorder patient. And the key thing here is the brighter is, the more activity there is in that individual. And you can already see just visually that there's significant differences between the two. And you can actually use this as a diagnostic. We've done this in schizophrenics and shown that you can have more than a 95% accuracy in differentiating between the schizophrenics and the control patients if we measure both heart rate and activity in the patients. But of course, wearables give us the potential to record so much more. In the top right-hand corner there, you can see a tracing of somebody's sleep staging, and that's just from a wearable on the wrist from something that we'll be using early on in the trial called the OPT3, made by Jawbone. And they have a nice API to pull this out. And actually, there are several studies to show that you can approximately sleep stage from this. These are independent studies, so it's not a bad device for doing that. But there's so much more that you can collect from the mobile phone. We're also collecting social networking activity. This is the number of phone calls and text messages two individuals are emitting and receiving over a period of several months. And one is, again, bipolar and one's a healthy control. And there are significant differences in their social networking. And more excitingly, perhaps, it's a way that we can tease out different types of illnesses as well. We've seen that with physical illness, your social networking activity goes up and your physical activity goes down. And with mental illness, your social networking and your physical activity both drop. So teasing out depression from a physical injury is something that we can start to do with these type of devices. Of course, context is essential, so we're also measuring somebody's location, but we're doing this in a de-identified way. So we're taking the modal point that you visit most frequently, and here you see a 2D histogram on a 40 by 40 kilometer grid of a particular individual moving around, and the central point turns out to be their home. And you ask me, well, how do I know that for sure? Well, you can look at the data just at the nighttime and see that almost all the data is concentrated in that one point at 0, 0, and that there's very low variance there. So it's not likely that they're a night shift worker and that's work. Otherwise, there would be a higher variance there. And then if we look at the weekdays, we can see another spike in the background, and we see that that is the workplace of the individual. And how do I know that for sure? Well, if I just cut that down to working time location, working times in the weekday between 9 and 5, you see that the spike increases in the background. So now we know the location of where they work and how often they're there. And at the weekend, that work location disappears. So clearly they're not an academic. All right, so what else can we do though? We don't just have to measure the data that's coming off the sensors on the phone. We can also harness some external APIs, pick up, this is my route to work, and it notices that I'm cycling, it saw I went out for a pizza. Then I can cross-correlate that with Google traffic and work out how much exposure I had to pollution. And then I can map that onto an external database of pollutants from satellite data, which is what you see on the right there. And you can see that that changes over a 24-hour period. I can identify the time and calibrate exactly what my pollution exposure is. So the future's basically now, I think, with mHealth. We've got to the point where we can do these big mHealth trials. We can use physiology and patches. We can get natural behavior data scraping from the smartphones, and we can use off-body sensors, video cameras, satellite data, traffic from Google, and knit all these different data sources together. But this doesn't necessarily mean that we're going to be successful. And this is one of the key parts of our project, and I think possibly the most important part of our project is that we're working with the communities to make this work so that there's a level of trust with the use of this kind of technology. Because many of you are probably sitting there saying, wow, that's incredibly invasive, the amount of information you're going to get from these people. And even though we've done this on mental health populations, it doesn't mean that it necessarily translates in general. And in fact, the African-American population in the United States has a long and troubled history of research that has not necessarily been aimed at their benefit. So everybody's fairly familiar with the Tuskegee study, and if you're not, you should read about that very quickly. The Jackson Heart study revealed some very interesting ideas about what people did with medical research. And almost 60% of people thought that medical research generally treats people fairly, but they put themselves at risk. Half of these people thought that it put them at risk if they participated in medical research. They also felt it was too hard for them to understand, and a significant portion of people thought it was a way for the government to keep them down, which is not surprising if you see the history of what we've done as a nation in terms of engaging the community. So the Jackson Heart study had a very innovative approach. They brought scholars in from the community and trained them to work within the Jackson Heart study, and many of them have gone on to very, very successful careers. So inspired by that, Dr. Taylor and I got together and said, how do we do this with an mHealth approach? And of course, there's an easy idea of deploying your mHealth application, but how do you get the community to trust this? How do you engage them properly? So what we proposed to do was basically take a section of the community, train them in how to build the app with us, and have them advocate, feed the information back to the communities, and feed the community information back to us on what is appropriate for their particular demographic. And as a byproduct of that, of course, we build software, we build community, we build trust, and we also empower the individuals onto better careers as well. So there's a very tangible benefit for the people that are involved in this. We've been doing this as a partnership with Tech Square Labs, and also as part of the Opportunity Hub and the Tech Hire Initiative out of the White House. Rodney Sampson is leading this out of Tech Square Labs, and we've been working very closely with him, and we have several of his first cohort working with us. It's a 12-month residency program, and we have 5 of the students now on paid internships at Morehouse School of Medicine, Cardiovascular Research Institute, and my Department of Biomedical Informatics, working with us on this, this particular initiative to bring the research into the community. And if you want to look at this on Twitter, it's hashtag CodeStart. These are our first 5 guys here who are sitting right outside my office right now, hacking away at the software. Rodney is there bottom left in the middle, and I'm top left there. The Tech Hire Initiative is really exciting, actually. There's been a follow-up grant of $4 million to train 450 new software developers in the Atlanta region over the next 4 years. We're going to continue working with these cohorts and bringing them in to engage with the community and get a trickle-down of knowledge into the communities to try and empower them. So the bottom line is health research and care are uniquely powerful economic multipliers. Research improves health through discovery and innovation, preservation of health increases opportunity and productivity, providing healthcare as an economic driver, and health and IT are 21st century versions of this phenomenon. And the South, we believe, is a mecca for healthcare IT and an important portal to the future of healthcare research and health equity. And with that, I'd like to thank the NSF for funding this. Very, very exciting opportunity. It's a privilege to work with everybody on this. And these are our partners, of course, and these are the partners on the grant, and I'm looking forward to working with everyone. Thank you.
This is fantastic. Thank you. I know, Gari, I think you said you're going to have to cut out at 1. So I don't know if we should just have 1 or 2 questions for you now before moving on to Santos, but I would like to have more of the roundtable with you as well. Are there any questions from the audience? We'll take 1 or 2 questions.
Yeah, and I would say if you're online, you can either chat it in the box and we'll read it, or you can unmute yourself and just ask.
I have a quick question, Gari. How much data are you working with? Are you going to be working with like a petabytes of data, or what's the amount you would need for storage and compute for what you're doing?
Yeah, that's a good question. Depends on the size of the cohort. We collect around 20 to 25 megabytes of data. And so that can add up very, very quickly. It depends on the length of time. I mean, one of the projects that we're also engaging with is the Healthy Aging Study. That aims to track 100,000 patients over several decades. So if you can support the app for that period of time, then we're talking petabytes of data. But I still think it's entirely processable. It doesn't feel like a lot of data to me, even though compared to most health studies, it is a significant amount of data. In fact, only when we move to doing things like video sleep staging does it start to get enormous and potentially out of hand at this point.
Oh, does anybody else have questions they'd like to ask for Gari? Anyone on chat? Okay, there we go.
I'll jump in with a question. Hi, this is Tim Brick. I'm at Penn State. One of the things that keeps coming up, can everybody hear me? It sounds really noisy.
Yes, we can hear you.
Okay.
I've got a helicopter standing behind me at the Children's Hospital, so I'm just going to mute myself a second.
You talk about a bunch of different approaches, different solutions that seem to use a lot of commercial tools. You mentioned Google's, you mentioned Fitbit, or Jawbone, I guess. All of those have APIs that require that data be shared with the company. That is, that Google tracks everything that happens on its API. Jawbone tracks everything that happens on its API. Are you concerned about privacy issues when we're doing scientific data collection that necessarily involves data sharing with a private company that may or may not follow, for example, ethical guidelines on those rules or on those data?
Yeah, that's a great question. So the data from Google actually is data that they're essentially collecting with you anyway. So the question of whether they follow any ethics like to that is, it's not that we're sharing the medical data on top of that with them. So, to be able to do anything with this, you actually have to have a link back to the medical endpoints, which we're doing separately. It's actually done through the app, but those ties into the medical record are not open to the third-party companies. So the question of whether they can do an ethical with that is moot. The question of whether the individual trusts those companies in the first place, though, is a key one. And that's one of the reasons why we're working with the communities to actually work out exactly, because I think the answer to that is it depends on the community, depends who you're working with. When I first started doing this, one of my populations actually was a mental health population, and I actually thought that they would be the most resistive to it. And actually, I found that they were one of the most accepting to this kind of analysis because they really were almost desperate for some kind of insight into their behaviors and how they could help manage them. Whereas I found the most paranoid group of people that when I first started doing this was my own research group. I don't know what that says about me as a supervisor of what they thought I was going to do with their data, but it made me realize that, you know, the people who you think are going to be distrustful of the data collection are not always the people who are the most distrustful, but there is going to be a spectrum of people. So one of the things that we do with the app is we give the user full control. They're able to switch the different parts that we track, so location or social networking or physical activity, they're able to toggle them on and off whenever they feel like it, so that they essentially have full control over the data collection. And then they can log on to a website, see the data, and choose to delete it as well. Now, if Google's actually tracking them in parallel, which they are tracking your behavior if you have an Android phone, and the same for Apple, then you can't delete their data. Actually, Google's pretty good. You can go into Google and delete your data with Google. But one of the interesting things we're doing here is working out how do we build a health literacy and a information privacy literacy educational program around this, because most people don't think these things. They just give their data away and don't worry about where it's going to go. They post things on Facebook and tweet stuff and don't worry about the consequences. And I think that's an important empowerment side product that this project will also have.
Yeah, I think you may find that one of the reasons your research group are the ones that are most paranoid about it are because they're the ones who have the most idea of what you can do with that kind of data.
Or they're paranoid about what I might do.
That's also possible. Thanks very much.
Welcome.
You know, I would actually agree. I think people are, it's not that they don't care, it's that they're unaware of how the data could be used, and they are unaware that the law doesn't protect them. I think they read these tiny little print things, and it says that they'll do what's in the law, and they assume the law will protect them, and it won't. Well, I think those are excellent points. We're going to move on to Santos, but hopefully there will be an opportunity to talk a little bit more with Gari before he leaves, but at 1 o'clock. But we also would hope that we can engage via email as well, so we can provide that information. So with this, I'd like to invite Santos Kumar. Santos is a William and Murray Moss Chair of Excellence Professor in Computer Science at the University of Memphis. And Popular Science magazine has named him one of America's most brilliant scientists under the age of 38. He's in the Brilliant 10. Is that like the Magnificent 7? Kind of. So his current research interests include mobile sensor systems and mobile health. He's currently director of the NIH Center of Excellence in Mobile Sensor Data to Knowledge that involves 20 investigators in computing, engineering, and behavioral science. So with that, I'm very excited to have Santos Kumar. Can you hear us, Santos?
Yes, can you hear me?
Yep, yeah. Wonderful.
Okay, so again, welcome everyone, and it was very nice to hear the project description from Gary. What I'm going to describe will be related but a little bit different. What I'm going to talk about is what we are doing at this MD2K Center of Excellence and what resources that we are building for the community. So this project is funded under the Big Data to Knowledge initiative of NIH, and it also has a companion support from National Science Foundation. I'll talk about both of these. So in 2014, NIH funded 11 centers of excellence under its Big Data to Knowledge initiative, and our MD2K Center is the one that's headquartered in Memphis. So although we are headquartered in Memphis, it does involve 12 institutions spread all across the country, and they cover, of course, computing, but also medicine, behavioral health, and electrical engineering. So it is truly an interdisciplinary effort. So what I'm going to present, the MD2K work that is made possible by our amazing team of 20+ investigators from both data science research side as well as health research side. and supported by our amazing staff here in Memphis. Overall, when all the students and the postdocs and all the staff are included, MD2K represents a team of 50+ individuals. So let me first quickly talk about things and expand on things that Gary mentioned. So mobile sensors, they present us with tremendous opportunities to observe a variety of health-related aspects of life. We can measure exposures, visual exposure, pollution exposure, digital exposure, and geo exposures. We can measure a variety of different behaviors, whether sedentary behaviors, activity, eating, smoking, conversations, and addictive behaviors. And then we can also measure outcomes. So, essentially what we can do with mobile sensors is we can measure the risk factors as they happen in natural life, and we can measure their effect on the individual. So that provides us with a very powerful platform that can help us both monitor and improve health in a variety of different ways. The way I like to project it is in terms of this detect, predict, and adapt paradigm. Sometimes we also call them sense, analyze, and act. So the detect part is that the mobile sensors that can help with early detection. So detect the onset of a disease before irreparable damage happens to the end organs. Predict part is, since we are able to monitor both the risk factors as well as their effects on the individual's health, then we can look back at the sensor data and be able to identify the major antecedents and precipitants that may have resulted into a health outcome, and if so, that can go into designing an intervention that can be delivered anytime that those predictors indicate that such either adverse behavior or adverse health outcome may be imminent. And then adapt part is that since these mobile phones and the sensors, they are aware of our surroundings, then they can help us adapt the intervention to suit the individual and their context. For example, we can now choose not to prompt an individual to fill a self-report or do deep breathing exercise while they are driving. Perhaps we can change that to maybe make changes, adapt their music level or ambient display in the car, but not ask them to do something actively. Or if they are rejected to be in the meeting, that may not be the best time to buzz them to fill a self-report. And also, since we can see the compliance, if we ask an individual to do something, whether they did or not, from that you can pick from the right personalization level and do various trials to find truly what works for the individual. So this platform, the mobile sensing platform, is essential to achieving the vision of precision medicine. So in MD2K, all the approaches we are developing, we are showcasing that it indeed can generalize to a wide variety of health conditions by putting that to test on 2 health conditions. One is the smoking cessation, and the second is the congestive heart failure. In both cases, first task is to do an early detection. For the case of a smoking, be able to detect, say, first lapse in a smoking cessation attempt by wearable sensors. That can help us identify the major triggers of the first lapse, which can then be used for a launch a sensor-triggered intervention to manage, say, their stress or their craving episodes or temptations when they are close to smoking cues. For the congestive heart failure, the early detection part is to be able to monitor, say, their lung congestion or from inactivity or from, say, fatigue, and be able to feed that into a model to be able to detect or predict rehospitalization so that their diuretic dosage can be adjusted and prevent a rehospitalization. And then once, because we can track both the changes in their health state, worsening or improvement in the symptoms, as well as the status of their lungs, we can see whether indeed the salt intake increases the congestion, or from an improvement in activity reduces congestion, and if so, those can be presented to the individual itself as to what behaviors that they are engaging in, whether it is fast food eating or lack of inactivity, as to what effect it is having on improvement or worsening of their health symptoms, and what alternative activities that they could do that can help improve things. So we can get to prediction, once we have these devices for accurate detection and tracking of the health state. So there are various mobile sensor data that we collect in MG2K. So our mobile health app that I'm going to talk about shortly, that can collect raw high-frequency sensor data from a variety of wearable sensors. First is the AutoSense sensors that includes ECG, respiration, and extrometry, worn at the chest level. Next are the wrist worn sensors, Microsoft Band and the motion sense sensor. We can collect raw accelerometer and gyroscope data from them. Then we can also collect data from the resident sensors in the smartphone, GPS, accelerometer, and self-report. And then there are several other devices from which data can be collected when they are used, like EasySense, that tracks the heart motion, lung motion, and the lung fluid level. That perhaps changes not as quickly, so you can collect data perhaps at the daily level. Similarly, the weight or the blood pressure, they can also send data directly to the smartphone, and the smart toothbrush, they can send data directly to the smartphone as well. So all of this data can be used to develop a variety of different markers of human health, human behavior, and the environmental state. So we have developed models for stress, smoking, cocaine use, and conversation, all from these wearable sensors. There are several other markers that are in various stages of development and validation. That includes eating, craving, brushing, watching TV, fatigue. Both of these, the watching TV and the fatigue from, say, wearable eyeglasses. Then lung fluid congestion from the EasySense sensor, and then this geo exposure to fast food or tobacco outlets from the GPS. So I'll quickly talk, try to illustrate the challenges in developing any marker of human state that works robustly in the field environment. So first, if we are talking about any of the markers, so we talk about physical activity and calorie expenditure from a wrist-worn sensor. Let's say we want to detect, say, smoking behavior from the wrist-worn sensor. So if a smoking event or a smoking puff lasts about 3 to 4 seconds, and the sensor is worn for, say, entire day, that consists of tens of thousands of seconds of data. There, if we suppose want to detect this smoking by looking at this unique breathing pattern that is associated with the smoking. So then there are 10,000 breaths that people take in about 10 hours. Out of those, there are only very few that represent a smoking event. If we want to detect the smoking event by hand-to-mouth gestures, there are about 2,000 hand-to-mouth gestures in the day, of which only 6 to 7 would be the positive instances related to smoking. There will be many more, like eating, that we can do for eating or drinking or yawning or during conversations and so on. And if we develop a system that is, say, let's say 10% accurate, a respiration-based system that is 90% accurate and has 10% false positive, that will not be usable in the field, because if you think about the 10,000 breaths that occur every day, 10% false positives means that there are, 100 false positives in the day. So that, if you're trying to detect if, say, smoking lapse, 100 false positives per day will lead to an unusable system. So what I'm trying to communicate here is that for a field usable system that tries to detect these discrete activities, we need a very high accuracy and quite low false alarm. The other challenge in having a generalizable system is that there are various different ways that people hold their cigarette. And then the same person, when, say, they smoke while driving, it's a much different event when they are standing and smoking, or talking and smoking, or seated and smoking, and say, drinking and smoking. So there are lots of different situations, and trying to capture them all is, is quite challenging. So the next, so what I'll just quickly mention that, we did develop a model and we applied the model onto an independent data set of 61 daily smokers who wore the sensors for 1 day pre-quit and 3 days post-quit. The system was able to identify all the 28 first lapses where the data was available, and the false alarm rate on the abstainers was limited to about one false alarm every 6 days. But there are, lots of limitations in this work, in this model. If as opposed to say a CO monitor that people can blow even several hours after smoking and you'll still be able to detect them, for these kinds of sensor-based methods, if they are not wearing it, you can't detect they're smoking. If they took the sensor off while they were smoking, there is no way that we are going to detect it. If the data quality was not good at the time of their smoking, we can't detect it. Also, this model would not work directly for e-cigarettes. That needs to, further adaptation. So the benefit of these sensor-based methods, as opposed to say a CO monitor, is that you can get to precise timing of the first lapse or precise timing of smoking. But then there isn't anything else that exists out there that we can use to validate this temporal precision that we get from such systems. And so that validation represents another challenge with such systems. So, you can read more about it from a paper cited above. Similarly, we developed a model for detecting cocaine use from heart rate data. There are several challenges in here as well, and I'll encourage you to read the paper. But the main challenge here in detecting cocaine use from the heart rate data in the field conditions is that in the lab you cannot administer the 600 or 400 mg of cocaine that people take in the field. Also, you can't ask somebody to walk on the treadmill right after taking cocaine, whereas that's exactly what happens in the field, that people walk around even after taking cocaine, and the response of the heart rate, from cocaine or from physical activity is quite similar. So how do you disentangle the effect of cocaine on the heart rate while the physical activity is also continuing? And those are some very interesting challenges. So the other issue, because you can't replicate the field conditions in the lab, is you can't just apply blind machine learning to feed this data and to get a model that will work in the field. So therefore, what we did here was that we developed a physiologically informed model that tries to model the autonomic nervous system response during the recovery from physical activity, or the dampening of that recovery due to the presence of cocaine in the bloodstream, and that helped it generalize to the field. So we applied this on 4 weeks of sensor data from 40 polydrug users who wore all the sensors for 4 weeks, and we were able to detect the all the 27 cocaine use episodes for which there was good quality data, with a false alarm rate of about 1 per day. So again, similar issues as the previous case, that if they're not wearing the sensors or if the data quality is not good, then it's not there is no way to detect it. So, the moral of the story here is that to develop a model, there are numerous exciting opportunities to track various risk factors as well as health of state from these mobile sensors in the field environment. But there are challenges of validation, there are challenges of modeling, and so blind machine learning is not what we call mobile sensor big data. Mobile sensor big data really means that being able to understand the phenomena and develop a model that will have a high chance of working in the natural field environment. So, so to so thus far I talked about going from the sensors to the markers. So collecting raw sensor data in itself involves lots of challenges. To have a long battery life so that the sensor lasts at least a day while streaming data at high rate, that is one challenge. And at that level, if the sensors are collecting raw data, you're talking about millions of samples that you get every day. When you convert it to markers of, say, activity or sleep or stress, then you reduce that high rate of sampling to about several thousand per day. But if you really want to do sensor-triggered intervention, how many interventions will you be willing to tolerate each day? Your phone ringing and asking you to do deep breathing exercises. There are only a couple of times a day that we will be receptive to these interventions. So the challenge is that to take those, millions of samples of sensor data, converting that into thousands of samples, and then from thousands of those samples, being able to identify those one or two, those few episodes in the entire day's worth of data, when those are the right moments to intervene. So sensors do provide us an approach to, a possibility to do sensor-triggered intervention, but it involves analytic challenges at many different levels. So, so next, I would like to jump into what resources the MD2K can offer to the community. So our approach, the reason we have been able to develop all these various markers and be able to validate them repeatedly, in these various data sets is that right all along we have been collecting raw sensor data as opposed to collecting, say, activity levels or only the sleep durations. We collect raw sensor data, and the benefit of it, to communicate the benefit, I would like to cite the example of this biobank. So, when people traditionally do research in biomedical fields, they sometimes collect only the assays. Other times, for longevity and for future usage of the data, they, archive the biospecimen. That allows you to go back to the biospecimen and derive new markers or to validate the previous markers. So, if we collect only the markers, then we have much less data. As compared to when you collect high frequency, but then you have no option of going back and either improving your marker or validating your marker or getting any new marker from previously collected data, which is what you get if you collect raw sensor data. So, so MD2K has developed this open source software platform, call it mCerebrum, that allows you to collect raw high frequency raw sensor data from a variety of different sensors. It is able to do this real-time data quality assessment to check whether people are wearing the sensor appropriately, and it can prompt them to fix the data quality before it's too late. Then, as Gary was mentioning about the privacy controller, there is a privacy controller for participants to be able to control which sensors and which data they want to suspend collection, or they want to go back and request deletion of those. Then all the sensor data is fed into the machine learning models, all right on the mobile phone, and that those models can convert the sensor data into these various markers, and those biomarkers can then be used to infer these episodes, which major episodes or major events, which can then be used to either trigger for self-report or to trigger interventions. And all of this can happen right on the mobile phone itself. And of course, all of this data can then be offloaded to a cloud, and a cloud version that we have developed is called the cerebral cortex. So all of this, software is available for anyone to be able to use freely. So the key capabilities of mCerebrum is that it can collect sensor data at more than 800 plus hertz for about 70 million samples per day. Can connect to a variety of different sensors via a wide variety of radios. You can get continuous data collection as well as real-time data quality monitoring. You get real-time computation of biomarkers, which can then be used to trigger notifications or interventions. There are a variety of different, there are several studies at many different sites that are currently in the process of using this MD2K software, and I would encourage you to explore and make use of it if you can. So right now what I've presented is that if you have the resources and ability to collect all this data of your own, then lucky you, but there are several data science researchers who may not have the right resources to collect this data, but they have the right talent and the interest to explore this data sets, to do further data science research, to improve various models, and then advanced computing or advanced health research. But sharing of this data has been pretty hard. So now that I talked about various tools that can be used to collect this high frequency sensor data, and now if we facilitate its sharing, it still needs a provenance cyber infrastructure that can annotate all this data so that any third-party researcher can make sense out of this data, and that will allow for reproducibility and comparative analysis, which we certainly need to make mHealth a truly scientific discipline. So thanks to NSF for a new data provenance cyber infrastructure grant called MPROV, we are developing that companion provenance cyber infrastructure as well to facilitate the sharing of data at this high frequency raw sensor data level. There are various challenges, as you may have guessed, but here I'll just There are lots of challenges that require a new proven cyber infrastructure development if this is to be applied to raw sensor data. So there are several other resources. There is an mHealth hub that you can get a lot of mHealth related resources at, and then MD2K annually conducts this mHealth Training Institute at UCLA. If any of you are interested in getting into mHealth, you can apply for it. And on this last slide, there are links to various resources that MD2K has for the community. Thank you.
Wonderful. Thank you, Santosh. Do folks have questions that they would like to ask, either through the chat or by unmuting themselves so they can ask them directly?
This is Gari Clifford. I've got a quick question for Santosh if no one else has.
That's great.
So, Santosh, very nice. One of the things hidden in the many slides, or not quite hidden, but was a detail many people have missed, is that it's absolutely vital to assess the quality of the data coming off the phone before you pump it into any algorithm. And you've got these quality metrics for determining whether you trust any of the parameters coming off the devices. Could you just explain quickly which parameters you've developed quality metrics for, and whether they're device specific or you've found some way of generalizing them around any generic device, for example, the accelerometer?
That's a good question. So, many of these, devices, accelerometer, for example, they include, if it's accelerometer, all you need to know is whether it is worn by the people or not, and then worn at the right location. So whether it's worn by someone or not, that I think is included in many of the commercial devices. But what we have is a simple threshold-based methods on the accelerometry values to indicate whether it is on the person or it is on the desk. Then for say ECG sensors or for respiration sensors, there are ways to detect whether there is signal is saturated, or does it represent the right waveform that shows whether the sensor is worn on a human body.
Thanks, Santosh. I've got lots of other questions for you, but I'm going to catch up offline.
Well, actually, Gary, why don't you jump in and add one more question there while people are queuing up to ask their questions?
Sure. So it's a very technical subtlety, and it might be distracting from, the main drive here, which is that you've got a very nice open source platform here for doing this. And detecting these behaviors is absolutely key. But the hidden in my last question was the fact that a lot of these devices have lots of different responses, biases, offsets. Let's say, for example, you're measuring the accelerometry from somebody. How do you compare, your Samsung Galaxy S6 with your Nokia N95 or whatever, and know that the variations in the accelerometry mean the same thing?
Yeah. So we convert those into the measures of gravitational accelerations and measures of G before we apply it into the models. And then we resample it to ensure that the rates are the same standard that's used input that is input into the model. Does that quick answer help?
Yeah.
Okay. So do we have any questions from people on the phone? Either through chat or unmuting your mic to ask the question directly.
I can ask another one at Santosh if you don't have anybody.
Sure, please do.
So Santosh, you mentioned it was open source. What platforms have you developed it on? And if somebody wanted to use the code base, where would they go to get it? Sorry, I see the GitHub MD2K org link.
So on this last slide that I have on the screen, all the links. of the documentation as well as the platform. I mean, if you want to download just the software, and the software is configurable too, so meaning you don't really have to go into the code if you want to just change the self-report questionnaire, or if you want to just change the various, which sensor should connect and which ones not connect. So there are lots of things that can just be changed by changing configuration files, and that doesn't require changing any of the source code.
And I'm just looking at it now. So you wrote this for Android or
yeah,
iOS?
this is Android.
Which is probably a conversation that we could have for a long period of time about the advantages of doing it on an Android, and then what kind of patient population we're selecting out by having to ignore iOS.
Yeah, so it is about the rate of progress, not a choice. So in future, we will have the iOS version as well.
So what we found with with iOS though is that it's very difficult to have a service continually running on the platform. I know we talked a little bit about this in the past, and there are some hacks around it, but they end up draining the battery life considerably.
Right.
So are you finding ways that you can actually keep the service running continually, or do you have to use or relaunch it all the time?
It does require some of the relaunching. It also requires making adjustments with respect to what frequency of processing we will do. So meaning that the sensor's data comes at the rate of 800 samples per second. So if we are doing the processing as the data arrives immediately, that will mean that we are draining the processor and the battery very, very quickly. So it requires to find the right balance of at what rate the processing should be done, then how the computation results can be shared rather than having to do recomputation. So the Cerebrum itself consists of about 20+ apps, and so there is appropriate sharing of both the data and the results of computation, and then adjusting the rate of computation to be able to balance the battery life and the load on the processor, so that Android would not repeatedly kill the various apps. But when an app is killed, then yes, regeneration is the approach.
Thanks, Santos.
Sorry, quick question for both of you. It sounds like, Santos, you have a great platform. With the South BD Hub, we can hopefully pull together some infrastructure and resources and other things. What would you see as being most helpful that the South Big Data Hub could do for you in these two initiatives, or to support the mobile health research community writ large in the region?
Santos, you want to start?
Sure. So I think we would like to have the first community, the data science research community, know about it. And so if they begin to use it, it will be great to have them contribute to it. And this becomes a community resource and not just resource that we are hosting. There are a variety of different other sensors that can be integrated into it. There are a variety of other applications or other studies for which it can be adapted. And if those versions are also posted back into the repository, then more and more people can begin to use the platform and be able to learn and compare one model versus another, which is not what we are able to do today. So, there is a lot that we can accomplish by being able to share and contribute and grow this platform.
And from my perspective, I think it's the same thing to some extent, that it's getting a wider community involved in this. What we're building is open source as well. Now, I've been talking with Jim Ray over at Georgia Tech about how we, in the long term, fuse together what we're doing. The key, I think, is talking about how do we, from my perspective, how do we scale this to be monitoring hundreds of thousands, millions of people simultaneously. And although it seems like an easy thing to do when you're talking about having a cloud analytics platform, it's important to realize that it's not as simple as that. You know, you've got a lot of data coming in from hundreds of thousands, millions of people around the country, and being able to construct the right infrastructure to be able to capture that and process it in a timely manner and share it with the right researchers, I think is going to be very important. And it's part of what we're trying to do, but I think it's something that the whole community needs to be in on, the whole research community. And I can see the South Hub as, you know, a leader in that.
So I don't want to monopolize. Does anybody else have questions? Or that Gari and Santos, I plan to follow up with you on these, how the hubs can help meet your needs. Does anyone else have some questions to jump in there?
I can also say that you've already started helping us. Actually, I sent one of my team who does all my Amazon backend. You recently ran a Microsoft Azure platform training day down in Texas, and I sent one of my key cloud engineer down onto that. But you're already helping us, and I think you know, having a cloud agnostic structure, I think, is going to be very important. We shouldn't be necessarily tying this into one cloud infrastructure. Keep everybody on their toes.
Yeah, and there will be more Microsoft trainings. We will be announcing the Microsoft Award with the terms and how it'll be structured, how it'll be distributed to folks coming up soon. So we're getting very close to a final agreement with them across the hubs. Does anyone have last questions? Otherwise, we will conclude and share out the slides. The recording of this will be provided. It'll go up on the blog page. I think we are posting them to YouTube as well. All right. Last chance? Okay.
Thank you.
Thank you both. This was fantastic.
Thank you.
And Gari and Santos, I'm going to follow up with an email about this, how the hub can help meet some of these requirements that you've suggested. So
Great.
Thank you very much.
I'll touch base with you as well, Santos. Thanks.
Okay. Oh, and before you all sign off, in January on, is it the 11th or 12th? So that week, we are planning to schedule our next mobile health discussion with researchers here on pediatric asthma and other applications. And I think Arlene, we've got an email coming out to you from, I see Arlene's on the phone, from Ashok. So with that, thank you all very much.
Thank you.
Thank you.
Bye-bye.
Bye-bye.